Now we're going to have Dr. Nicole Redmond from the National Heart, Lung, National Heart, Lung, and Blood Institute present for us.
Good morning. Oh, good. Y'all are good. I'm Nicole Redmond. I'm originally from South Carolina, so I like that call and response. So I'm also going to probably end up talking really fast because I have a lot of information that I want to cover, and I want to be respectful of the other speakers. But I'm so glad that we had this great introduction of to the correctional system that you have here in the state, and a lot of the points that I'm going to go over really exemplified by some of the information that was shared by Dr. Carr. So I'm obliged as now a government employee to be sure that you're aware that the views expressed are my own, and I do not speak on behalf of the NIH or U.S. government, and I have no financial disclosures. So. Oh, sorry. So this is going to keep me still, which is going to be a hard thing. I did my internal medicine training at Emory, and part of that training was at Grady, which is a large county safety net hospital, largely minority, largely low income. And I had a number of clinical experiences that raised my awareness around that issue, and I've just listed them here. So I had a young African-American male in my clinic, and I remembered him because he was one of the few young people that were in my clinic. I had a Wednesday morning clinic, and I had a lot of what I call LOLs, little old ladies. So I really remembered him. And the other thing that was memorable is that I knew when he was coming to clinic, because when I would look outside, there would be two security people outside the exam room. And so that was always really striking. And I remember this case being really frustrating because he had an interesting a prolactinoma, which is a growth in the pituitary gland that requires really close specialty follow-up. And I really struggled with making his specialty appointments, and then those appointments would get missed because of being transferred between correctional facilities. So it was really difficult to communicate with the provider. So I think your point was really an interesting one in terms of how well can the correctional health providers communicate with the community health providers. And then I talked to my colleagues, and they had other examples. For example, people going without medications and ending up in with severe diabetic ketoacidosis. A gentleman on the inpatient side who'd been incarcerated multiple times, multiple hospitalizations. And so how can we prevent these things? And so that led me to think about a lot of questions. So my interest has always been in health disparities research. That's how I met Leroy. He was my mentor as I embarked on a research fellowship at Brigham and Women's to learn about population health. And a couple of questions I had were, how does incarceration impact management of chronic disease? And so that includes both in custody and, as we're going to discuss more, post-release. How does it impact screening and prevention? As Dr. Carr stated, a lot of people, their first contact with a healthcare provider might be when they come into the prison system. And so what are the implications there as, for lack of a better word, an opportunity for screening and prevention? What are the implications in terms of access to healthcare providers there and then when they return to their communities? And then one of the challenges is when you're in the correctional facility is the limitations on your activities and how that impacts your self-efficacy in terms of managing your own health behaviors. And then the other thing we know is that there's a lot of disparity in who's incarcerated. And so how do those disparities in who is incarcerated dovetail with the disparities we know about healthcare status, particularly as it relates to chronic disease? So these were some questions I had. And so now I'm going to share with you some slides. This is kind of a little bit of a recycled slide set, to be honest, because at the end of my residency program, all the senior residents are required to do a grand round. And I wanted to unpack these issues a little more. And it was really quite enlightening, all of the different issues and challenges around providing health care. And so if I'm presuming that that most of you might be new to these issues, so I'm kind of going to start where I started in terms of learning about this and give a little background and context in terms of some of the barriers and challenges, and hopefully we can see some opportunities. So first of all, who is incarcerated? I wanted to just be sure, because this was something that I think wasn't really clear to me in terms of the different types, and I think this relates to some of the levels here that you have in the Delaware DOC. that there's a multitude of types of correctional supervision. Jail are typically folks that are awaiting trial, so the innocent until proven guilty, detained, probably couldn't make bail, so they're now detained until their court date or until their sentencing hearing. Prison, they've had trial, they've been sentenced, and it's usually longer term for at least a year or more. Parole is considered community supervision after incarceration. So someone's been in a correction facility and whatever the procedures are, perhaps can now serve the rest of their sentence under community supervision. Whereas probation might be community supervision in lieu of incarceration. And so I think those top two levels are equivalent, if I understand correctly, to the level 5 here in Delaware, where those other two might be the levels 1 through 3, if I understand correctly. So, okay, I'm sorry this slide didn't come out as clearly as I'd hoped with the copy paste, but this is just to illustrate how many people in the U.S. are under correctional supervision, and it's in the millions. So if you look at the total correctional population, even over the past decade and a half, it's hovered between 6 to 7 million. With about 2 million of them being incarcerated and the others under community supervision. And this slide is here to illustrate the disparities in who's incarcerated. And I think this was pretty well reflected in the charts that were shown for the Delaware DOC, that we have a disproportionate number of men versus women. Although, you know, we know, I think it's similar across the nation that we're having increasing numbers of women. That there's some racial disparities, so that minorities, particularly Black and Hispanic men, are incarcerated disproportionately relative to their representation in the general population. So now this is where I think it really gets interesting and really intriguing in terms of some of the legal and ethical issues around healthcare for this population. So one of the most striking things is that people under correctional supervision who are incarcerated are one of the few groups that have a constitutional protection for their health care. So that's something that we don't have in the community. And the origin of that is a 1976 Supreme Court case, Estelle versus Gamble, that saw that the deliberate indifference to a serious medical need was a violation of the 8th Amendment right against cruel and unusual punishment. And the definition of serious medical need is a need that would be obvious to a layperson. And then the deliberate indifference would require subjective knowledge of that need, but then not offering the necessary treatment or a delay in that treatment. And so following that, there was a lot of pressure to reform correctional health care. There is the quote-unquote wave of litigation, so a number of class action lawsuits, and we still see quite a number of those, even in modern times. Litigation by individuals and advocacy groups, such as the ACLU, all demanding this community standard of care. I'm going to talk about what that means in a bit. Then you have organized medicine, also developing standards specific to correctional institutions. And in 1983, the National Commission on Correctional Health Care was formed. And then an interesting thing in the 80s and 90s with mandatory sentencing and decreasing alternatives to incarceration, we see an increased number of inmates and an exacerbation of that racial disparity in incarceration. And also with that mandatory sentencing, now you're seeing a longer length of stay. And with that means that you have more inmates who are now aging in prison due to these longer sentences. So what are the determinants of a community standard of care? So first of all, you wonder, well, what is the community standard? I mean, we already know that even outside of correctional facilities, there's a lot of variation in where health care and health status is delivered across communities and for certain populations. And so, you know, I think it's not very clearly defined, but in terms of how that's translated to how that standard of care is defined for a correctional facility, you have legal influences, so all of those court-ordered mandates, responses to those lawsuits that then kind of set the bar for what is expected. There are the financial determinants, and so we mentioned the extreme high cost of care. I'll have to find the reference, but I've seen estimates of around $4,000 per inmate to provide that community standard of care, whether that's for the clinicians, medications, and such. The community standard of care is also defined by ethical standards, whether that's professional and staff codes of ethics. Of note, correctional facilities are not required to be JCAHO accredited, so that's a voluntary participation and accreditation by these oversight bodies like JCAHO, or the National Commission of Correctional Healthcare also provides an accreditation process. And then there's the challenge of the balance of security with public health, and I'll talk a little bit about that in more detail in a few slides. And then the community standard is also defined by the medical community in terms of just the usual evidence base that we have, clinical guidelines and professional standards, and standards that evolve with the healthcare technology. So what are the challenges? So now that we've set a standard, either by legal means, by the clinical guidelines and such, what challenges providing that community standard of care? So as we've stated, and you'll see this over and over, that these individuals have an increased burden of disease, both infectious disease, which I think gets a fair amount of attention, such as TB, HIV, hepatitis C, but also chronic disease, psychiatric illness, substance abuse. And then in particular, we have the special challenges of managing populations, women in maternal health, and as I mentioned, the needs of aging individuals. Then you've got the challenge with the cost of healthcare delivery. It's already really expensive in the community and a lot of challenge around that. And we're faced with increasing medical costs, but then also having the decreased public funding. So that puts a squeeze on the system. And then the challenge of balancing public safety with public health. We've got a correctional health system, but it's embedded in a organization that is designed around public safety. And so there's the need to address stigma and barriers, the balance of security and confidentiality. I found it kind of disconcerting as a physician talking about some personal issues with my inmate patient, with the presence of 2 security guards there. And then the challenge of reentry into communities. You want the protection of the public. So whether that's particularly, we think about this in terms of infectious disease, like the example of the person with active tuberculosis, but I think they're still addressing that stigma and barrier of having someone with this incarceration history back in the community. So just to emphasize, and this is primarily chronic disease. Again, this is, the kinds of things I think about now with the National Heart, Lung, and Blood Institute, but there's similar disproportionate impact of infectious disease as well, as we mentioned, that recent data for state and federal inmates and jail inmates shows, significantly more disease as compared to the U.S. population for a number of chronic conditions. So what are the barriers to providing the clinical care? We've talked a little bit about the community standard of what informs what we think we should be doing. And so what are the barriers for even actually getting it done? And we've touched on a lot of these from the prior talk and these are things that are common across the country. First is the prison demographics, I already mentioned, the aging population and just the increased number, the high cost of care, that community standard isn't cheap, and then with a publicly funded institution that really puts a squeeze on budgets. And another issue is that with a lot of the litigation, those claims end up driving up costs. We've talked a bit about payment of care, and I was really excited that the issue around Medicaid suspension was raised. When I was in Alabama, that was a non-Medicaid expansion state, so that option wasn't even really available. And so that's a challenge across the country of finding funding even post-release for this population. So both a challenge while incarcerated and in the transition back to community, and the delay in resuming benefits. I'm glad you talked about that. And then, some of the ways that correctional facilities get around this is that, they're not receiving, allowed to get Medicaid or Medicare payment while the person is in their custody. So they may actually release a patient and, for them to be admitted to the hospital. And so then the hospital is then caught in the middle and stuck with the care for this patient that doesn't have any health care coverage. And so that starts this kind of cycle of cost shifting. Some other challenges that were mentioned are the health records. And so I think that was a really great observation of how do we facilitate communication between these, the community and correctional health systems. So a lot of that is the inconsistent sharing. In Alabama, they didn't have an electronic health record. So they're paper charts, which then, it was even more challenging. And given some of the constraints around, having to release so quickly, the clinic may be closed, at the time that the person is released. If they're getting released at 7 o'clock at night, the clinic is closed. No one's going to say, well, I'm going to just wait and get my records. There's not a lot of coordination around that. And because they weren't Medicare and Medicaid eligible, then there was no incentive payments in terms of EHR adoption. I read recently that that was changed in 2013, but then that EHR adoption now lags for them because of the lack of incentive to even develop that for those systems that didn't have it. Then there's the challenge of recruiting, retaining, and training high-quality healthcare professionals. I mean, obviously, it's a very high-stress work environment, and there's a lot of the litigation has been around some of the more poorly trained or qualified providers just providing suboptimal care. And again, this isn't exactly a career path that a lot of trainees, as they're going through their clinical training, exposed to as a career option. Lastly, another interesting issue is the outsourcing of medical care. And I'm going to show you in the next slide or a few slides ahead, a number of jurisdictions contract out their care, and there's a number of for-profit health systems that have these contracts, and a lot of times they end up making their profit by reducing the cost of the care that they provided, and a lot of times that ends up reducing the quality. There's also I have a question mark here because I don't know how, if this is more anecdotal as opposed to evidence-driven, but there is some concern that there might be less risk of malpractice because juries may be reluctant to decide on behalf of the inmates. But I think we've seen now there's enough litigation to show that there's that inmates that the courts will decide on their behalf, and that correctional health systems will have to be accountable for providing that community standard of care. And as I mentioned before, these systems are not subject to mandatory external oversight. All of that is voluntary. So then that lends itself to a good bit of variability in how they interpret what that community standard of care looks like. So then from the inmate perspective, what are the challenges? Well, quite obviously, they're limited in their self-efficacy. A lot of these individuals have poor baseline literacy or poor health literacy. Then once you're incarcerated, you're not exactly choosing your own healthcare provider or insurance provider. In fact, you're losing whatever insurance you may have had. Then you have limited access to even over-the-counter medications. Medications are usually dispensed, and there's directly observed therapy. They're very rarely kept on person or KOP. And in discussion at dinner last night, he even mentioned that, medications can even be currency. You can kind of trade, for other things. And so that you have to be really careful that people are actually taking the medications that are prescribed for them. And so there's that control. And then if you feel bad, there's no such thing as a sick day. In some cases, the process to initiate a physician visit might entail long wait times. Some inmates have the work programs where they're on site or with work release, and going to the physician visit then impacts their capability to work and get the stipends or allowances and such, or they end up having to make that up through a longer sentence in some cases. And as I mentioned, one of the big concerns I had was the compromise of confidentiality, because access to medical providers is always mediated by correctional staff. And it sounds like similar to my experience when I was in Atlanta, that here in Delaware, if someone's going off site, it requires two security officers. And so that puts a burden or stress on the staffing. And so then they have to really manage their staffing needs with getting the patients the care that they need. I'm not sure if this is still true, and maybe Emily, you know more about this, but at least at one time early in the HIV epidemic, they would have special packaging of those medications. And so then that would single out the inmate and kind of add to that stigma. I think a lot of correctional facilities may be moving away from that now, but that was an issue, at least early on. So then what are the barriers to research? So again, you know, a lot of the questions that I had from my clinical experiences made me think about things that would be worthy of study. And when I joined Brigham and Women and was working with Leroy, you know, he was really interested in this topic. And so we were hoping that we could, you know, maybe start to understand this a lot better and develop a research project around it. Well, that's where a lot of the challenges really came forth. And so at least in Massachusetts, you know, one of the challenges I had was just really figuring out who to talk to. So I think it's fantastic that we have some really engaged individuals here in Delaware with the DOC who are kind of aware of the issues and eager to work with you to address this problem. But as I mentioned, you know, the resources are slim. This is a publicly funded entity, limited staffing. You already see the budget is already stretched. So the resources available to do just one more thing, that extra, oh, let's get your medical records. Well, who's going to have time to find those for you and share those with you and make sure that they're accurate? The other challenge is there's just a really heterogeneous organizational structure across local, state, and federal entities. So to really get a national picture is difficult. You know, as you mentioned, DOC is unique in having this kind of combined jail, prison population in one, you know, in their facilities, which is a totally different way from other jurisdictions in terms of their management. And so really understanding, you know, what's different with prison populations versus jail populations. And then as I mentioned, one of the issues is that a lot of times third parties are contracted to provide health care, and particularly the for-profit partnerships, you know, there's not any incentive to share their records. You know, that's unless that's something specifically designated in your contract, they don't really have an obligation to provide any kind of records to you in terms of reviewing their quality or addressing any research issues. I will point out there are one or two jurisdictions that their healthcare is provided through academic partnerships. So I think of Texas in particular. I think UTMB provides healthcare and it even provides some residence training in correctional healthcare. Additional research challenges. Obviously, ethics and privacy concerns are enormous. And so prisoners are one of the special populations specifically protected by the Office of Human Research Protections, along with like children. And so that adds an extra layer to any kind of IRB process you have for human subjects research. And then on top of that, so you've got your institutional IRB, but then one issue we found with the Massachusetts DOC is that they also had their own facility process in terms of sharing inmate records and addressing privacy and confidentiality that then made that even more difficult. One of the other questions I have is looking at incarceration as an exposure unto itself. So for my researchers in the room, you know, exposure may be defined as, say, length of sentence, frequency of incarceration, level of incarceration in terms of moderate and maximum, and how is that impacting, how does that influence health outcomes or whatever health outcome of interest? Well, to really look at that, you need to link your criminal history records and criminal justice records with the medical records. And a lot of times those are completely different systems that are not linked together. And so to initiate that would be difficult. I already talked to you about data quality and access in terms of the lack of electronic health records, If you have paper charts, the difficulty in trying to obtain those records, chart review, and a lot of that time is not feasible. And then also the identification issues when people have multiple IDs, multiple names, alias names, of really making sure you have the right record with the right person. And I mentioned that the data management. The other challenge is the movement of the population from facility to facility or in and out of a facility. And so really doing that population health management becomes really challenging in trying to find the right person, match the right records, and then follow that person throughout their healthcare cycle. So I'll end with, the challenge of transition, and we've started to touch on these issues, and I think what you'll see in some of the subsequent speakers is some of the same challenges and issues tend to crop up. You'll hear this mentioned that, nearly 95% of prisoners are eventually released back to the communities, although a large proportion of them end up reincarcerated, so it ends up being more of a cycle. And I've mentioned all of these challenges to transition. I think Brita's coming after me, will talk specifically about some of the psychological issues. But, people who are already at higher risk as is, either due to their income status, socioeconomic status, racial disparities, and so on, then all of that is perhaps magnified through the challenge and access to care that they have when they cycle through the criminal justice system. We talked about the issue of aging, high disease prevalence, poor self-efficacy, the access to social support, the delay in insurance and coverage, and the psychological and social issues that Brita will talk about. But even with that, there are some opportunities, and I'm hoping that by the end of this session that you guys will start to see some of the strengths that you have here in Delaware, and having kind of one big major medical system and a very engaged, interested staff with the DOC, and being able to kind of overcome a lot of these challenges and barriers. As mentioned, for some of these populations, particularly low income, this incarceration and this constitutionally protected right to health care paradoxically might actually provide an opportunity to extend care to people who would not have received it in the community. So there's an opportunity there for diagnosis and prevention and treatment of disease early while they're young. Then there's the other challenge, and I think the Maslow's hierarchy of needs is that if you meet some of these basic needs first, then you can think about the longer term self-actualization of people. And so thinking of prison less as a punitive environment and more as an opportunity for rehabilitation and healing in all senses of the word might be a shift in thinking for a lot of people, but a way to maximize that opportunity. And I think the other thing for especially those of us involved in healthcare is remembering that the correctional health system is a part of the health system at large, and thinking of the correctional health system as a part of the public health safety net. And just as there's a lot of academic study around the best way to manage care transitions, for example, from inpatient to outpatient or to nursing home facilities, we can apply the lessons learned from those settings to the transition from correctional health care to community facilities. And so trying these care coordination and team-based care with the comprehensive social support services and co-location of services. And so I think Emily's model, as she talks about that, will give us some ideas about how to achieve that. And luckily, you already have really engaged correctional healthcare providers. But on the flip side, I think I'm excited to see all of you here participating to get trained on what you can do on your side of the handoff in the community and understanding the particular needs and challenges that this population faces when they return home. I'll just land on my final two slides. This is a position statement from the National Commission on Correctional Health Care. And again, they recognize the need for developing mandates around surveillance guidelines so that we have more of a uniform understanding of really what the needs are, and so that we can enhance this epidemiologic research so we can then manage this population a lot better. And that should include all of the stakeholders, law enforcement, correctional health, custody staff, so that they have a better understanding of what's going on and how to understand this and support large-scale research. And these are just a few bullets. It's a very long position statement, so I have that reference there. And as a matter of fact, there are a number of statements around healthcare issues from this organization that might be of interest as you guys move forward. And lastly, shout out to NHLBI. So interesting thing is I was able to participate in this workshop as faculty, and then now Emily and I are working together on hopefully a publication that covers some of the details of what we discussed in this workshop, but really trying to get people interested in looking at chronic disease, and of course my interest in cardiovascular disease in particular in this population. And again, we kind of settled on some of the similar conclusions in terms of trying to gather better quality data, more data, so that we understand what we're working with, leverage our existing investment in healthcare research from all levels of federal. So, one of the Transitions Clinic had support from the Center for Medicaid and Medicare Services so that we can learn how to provide care to this population at less cost, because ultimately a lot of them will be coming home and back on Medicaid and then eligible for Medicare as they age. And then understanding how we can work together with regulatory bodies and criminal justice staff to reduce and eliminate these barriers to research and providing clinical care. And so, but still respecting the needs, and understanding the ethical concerns around this special population. With that, I'm happy to take questions. I think they're reasonably on time. Yay.
Excellent job. Thank you, Nicole. You were perfect. We have time for a few questions. Just want to say that Nicole and I obviously have known each other for a long time. When she first came to Harvard, I think I was ill when you interviewed.
Right.
And it wasn't until after she started we met, and at our introductory launch it went something like this. You know people who have been incarcerated? I know people who have been incarcerated. Let's do research together. And we really began to, I think, comb through some of the issues that our patients face on a daily basis and some of the difficulties we have in healthcare. So I'm glad to see this work advancing. I think we can take 4 questions, and we're going to start with Dr. Jackson. Okay.
I really enjoyed your survey. This is a new, I have incarcerated family members, and so thinking about the healthcare issues is very intriguing. Couple of questions. The first one is patient-related outcomes as it pertains to publicly financed institutions versus private. Are there any differences?
I don't know about any data about that. So, yeah, I can't say that they are. I mean, I would expect that publicly funded institutions probably have a little more challenge in terms of their budgets and managing their budgets overall.
And the reason I was asking is there's recent press about decommissioning these privately funded jails or prisons, and so I'm wondering about the quality of care in the healthcare.
Oh, I see what you mean. So yeah, in terms of like with their for-profit contracts.
Maybe I'm using the wrong term, but the for-profit prison
Right,
systems.
right, yeah. So, I think that's challenging because they try to function, in kind of a capitated care system, but this population is more expensive, and so for them to meet their profit goals, then it makes sense that they would try to limit their care. And I think one of the challenges is that when some of these contracts are designed, that some of the deliverables aren't set up to where there's a level of accountability in terms of monitoring their quality. And so I think that's a challenge. And especially in, very poor states like Alabama, I know that they actually had trouble just getting contractors to bid. Like a lot of times they'd only have one bid because the budget was so low that, and people kind of knew realistically, like we can't provide the level of care that is required with that budget. And so I think they had a lot of challenge of, hey, we need $1 million care, but you only have a budget of $250K, so I think everywhere. So to the extent, I think that's a huge conversation from a policy standpoint as you work with your stakeholders. We're very focused on health outcomes and having a healthy population. They're really trying to make the numbers work, and you have to think about that kind of from the outset.
So I don't know that they're data, but I would say, if I may also respond that, I'm nervous, right? And so although I would not have the audacity to make assertions, what I can tell you for a fact is that for-profit companies, if you look at a wide range of them and what they state their primary objectives are, the first objective is always to improve the equity share of the stockholders, right? And that's sort of the primary motivation. And so it doesn't take a genius to extrapolate from that what that means in terms of cost containment. And so I have concerns. Thanks for bringing that up. I think there was a second question. Yeah, Dr. Weintraub?
So Nicole, it was a fabulous and very important talk. As an investigator, I just wonder your thoughts. This is private thoughts as an investigator, not representing NHLBI.
Yeah, absolutely not.
Yeah, absolutely. About your thoughts on how we should address research questions. There are all kinds of things we can do, and they're endless. We could look at an implementation of programs and process measures. We could have epidemiologic studies and randomized trials. The difficulties in randomized trials, I think, look to me enormous unless we're going to use process measures or surrogate outcomes. And then there's the whole transition from incarcerated care to post-incarceration care. And if you look at all of this, the spectrum of things to study becomes enormous. And I just wonder your thoughts on where we are best focusing.
So that's great, and I think, and Leroy can attest that, usually, especially when you're more junior person like myself, that you always have more ideas than you have resources to deal with, and so, and I can never remember all the representation, but the finer criteria in terms of when you decide on a research project, and the biggest thing is feasibility. And so, you work on the things that you really feel can be feasible within the system. So, and I think because of the heterogeneity of the type of system that you have, the engagement of any partnerships that you need to have, the support of your institution, what the final question or what an initial question that could be worked on is going to really vary. So, I know this is kind of a non-answer, but it really depends. One of the reasons I ended up getting focusing more on the post-incarceration is that's where I had a little more control. I couldn't access within prison, so I couldn't, even though a lot of times what'll happen is you'll get a lot of buy-in from the commissioner, and they say, yes, you can come in, but when the rubber meets the road and you actually need to say, okay, but what time do you do your discharge planning? The person who runs it won't answer your phone calls, doesn't check their emails, and so you can't get in there to even try to do, say, discharge planning. And so some of it's very practical. So then I focused, well, what do I have control over? I have a clinic, an injured care setting. I have a good relationship with my administrator. I can kind of negotiate that. So then that's what I will work on. And I think, so it's very challenging, but kind of running through those kind of what are the lower hanging fruit, where do we see support, and just running with that. I think any comments or your thoughts?
I think that's fair. So, where the good.
What we don't want to be is we don't want to be the drug looking for the keys under the street light.
That's
we
right.
Study this is what we can study. We also have to figure out that intersection between what we can do and what are the big.
Well, right. and I think the other thing is, the challenge is, looking at, are there some policies? A lot of times we as scientists think very clearly about science, but then a lot of times you have to think about the context. And so, like an example might be the Medicaid termination. And so if there's a problem, like we need people to have medication access, is that something that could be addressed directly? And so, and then how does that policy change then change outcomes?
I apologize. We're going to have to move on. Can I just comment on, just for the sake of time, and I'd encourage those of you who have questions, I'll ask the speakers to stay here for 10 minutes or so afterward to answer them. Bill, I would respond in part by saying this, though. If we think about our agenda for research in this area, it's just like translating this from the disparities literature. I don't need to see another paper that has an odds ratio of 0.7 to tell me that I, as a black male, am more likely to die from cardiovascular disease than white male my same age. So I would like to see more research being done, investigating what mediates those differences, which of those mediators are apt for intervention, and may be the best bang for our buck to go after, and then interventions to reduce disparities. And I think doing that in a pragmatic fashion is really our challenge.